patients who were already diagnosed and under our care, either receiving active treatment or on follow-up. And for all we knew, with the very scant data that had already emerged from other parts of the world, I suppose, especially Wuhan and Italy, the concern was that maybe our patients with an established diagnosis of lung cancer were going to be extremely sensitive to this virus and do very badly if they were exposed. Fast forward 3 months, I think we're in a very different position. And as Nicole was just implying, our experience with lung cancer patients has been that a lot of them have been exposed to the virus. A lot of them were symptomatic. A lot of them were with a PCR diagnosis proven to have COVID-19, but actually did pretty well despite that. You know, don't get me wrong, in no way should we be complacent about the impact of this virus, either in lung cancer patients in particular, cancer patients in general, or, you know, in society. Of course, manifestly it can do a lot of damage and is dangerous in some patients, but I think we now know from our own experience and from the emerging literature that COVID-19 and lung cancer are not the oil and water that we previously imagined, and a lot of patients have come through without too much trouble despite proven exposure to virus.
Would you say, James, during this, with all of the changes, you know, you said that was quite reassuring that actually cancer patients maybe not as big a risk as some other medical conditions that we've learned about, particularly elderly, diabetes, cardiac disease, etc. But a lot of changes would have gone on. I mean, what kind of changes did you have to make in your practice? Well, there was a lot of uncertainty.
So, I mean, the right approach was a precautionary approach. You know, when you don't know exactly what's going on, you have to expect and plan for the worst. As everywhere else, we brought in a lot of procedures which were designed to minimize patients' visits. I think the way to think about COVID-19 and cancer is in 2 layers. On the one hand, the one we've just been discussing is the diagnosis of lung cancer a problem in this context, and the other is a much more pragmatic issue. You know, are we exposing patients inordinately just by bringing them up to the cancer center? So that's something that was directly under our control, and me and some of my other senior colleagues really felt that it was our role to roll up our sleeves and get really involved just in the planning of clinics, for example. So rather than allowing nurse specialists and fellows to prep the clinics and decide who was going to come in and when, we micromanage that to begin with, to ensure that you know, those of us with the most experience could prioritize those patients who can wait, and those patients who really do need to be exposed to the potential risk of traveling to and visiting the cancer center.
Now, I didn't mention this when I was introducing you, but you also run a phase 1 program. And so I guess for those listening, phase 1 trials are research studies of some of the newest treatments coming into the clinic. And they're often really quite intensive in the amount of monitoring and tests. What happened to your research program?
Yeah, well, we could talk for several hours just about trials in COVID-19, I think, and I've written on that subject quite extensively, and it has been dramatic. The impact. On the one hand, experimental therapies, you might think, well, they're experimental. Why are we exposing patients to those? But we know that a lot of cancer patients want, and in many cases expect and require access to experimental therapies because their standards of care may not have been sufficient to control their disease. So it was with a heavy heart that we had to control the recruitment and eventually pause recruitment to all of our trials, not just phase 1 trials at our centre. And I think that certainly across the UK was a pretty universal step, at least in the you know, in the immediate moment of the COVID surge. Having said that, for patients who are already on trials and demonstrated to be doing well on an experimental drug, you know, one's in a bit of an ethical bind. On the one hand, you don't want to stop a treatment that seems to be working, and on the other, you know, some of these protocols, as you outlined, Paul, are extremely demanding of visits, and they're I was really impressed by sort of very early intervention from the UK trials regulator, who said unilaterally very early on in March that they expected deviations from trial protocols, whereby, for example, we might call patients at home instead of asking them to come and see us every week religiously in the clinic, and arrange more local blood testing, for example, if that was appropriate. So we were able to mitigate that risk to an extent, and for a patient, as I say, who's receiving a trial drug, doing well on it, being able to continue on that despite everything happening around us was really important.
Did you have to stop the new enrollment of patients? Because we had to stop since the beginning of March. I think that's the biggest problem from my point of view, because we've been able to continue the ones that were already on the trials, but the new ones, we're just starting to beginning the enrollment now of new patients. Was it the same in the UK?
Exactly the same, Nicole. Yeah, so the 10th of March was the date that we completely halted recruitment to all trials in our cancer centre. And we're only just coming out of that now and prioritize. It's much easier to stop than start, of course, with something complex like clinical trials.
And that was about a week ahead of us, I think. We were about a week behind when really Prime Minister Trudeau called all Canadians away, called them all home, and everything shut down. Nicole, can I ask you, what would you say that you've learned in the way you practice medicine, like a positive that you've learned that you would like to see continue now?
I think phone visits are really good for some point of our medical assessment. Not for all of it, but not for the respiratory part, I would say, but for some patients that have been on treatment, are stable, and they come, let's say, every 6 weeks. Sometimes to skip a visit in the hospital would be okay for them. So I think that's something we'll have to keep in the next future. Those phone visits. That's the first things. I think the other thing we had to discuss more with patients is the advanced care planning. Sometimes patients are afraid to talk about what they want, but with COVID, we had to discuss with them, and I think that's something quite positive that happened. We discussed more with what they wanted for their health, what are their wishes. So I think I'd like to keep that with the patients.
So more phone visits where it's appropriate, and certainly in Ottawa we have a lot of people who would be a couple of hours, 2-3 hours away, and be very easy to carry on with that approach. Advanced care planning, for those listening who haven't heard that phrase before, advanced care planning is the concept of thinking about important things and decisions that you have to make in your life if you're facing a serious illness like lung cancer, and it could be legal things like do you have a will and is it up to date, or have you appointed someone as a power of attorney to make decisions for you if you're not able to. It could be equally your personal goals. What's your bucket list if you didn't have as much time as you thought. Probably all of us should be doing that anyway, whether we're ill or not. But it's interesting that you brought that up. I hadn't really thought of that. Dr. Spicer, big positives that you've taken out of this that you're going to keep doing?
Yeah, I think you and Nicole have covered that. I think something, even if we have a global distribution of 100% effective vaccine tomorrow, I think there are some changes to the way we run our clinics which are going to stick, and you've outlined one of them. There's inertia is very potent in medicine, isn't it? And we often do things just because we've always done them that way. And I think we learned in just a few days that you can run an outpatient practice extremely well without having the patient physically there every time you need to have a conversation with them. So Nicole, you're obviously using a lot of phone conversations, as have I. Although the technology in the National Health Service in the UK sometimes lags a little bit, we've got going with video conferencing with our patients as well, and that certainly takes us into another league. I think being able to see the patient not just listen to them makes a huge difference in how comfortable you feel about assessing someone remotely, and doing that maybe serially in between face-to-face visits. That's been really important. And hand in hand with that goes actually treating patients remotely. So in lung cancer, of course, we have quite a lot of oral therapies, which are used in a lot of our patients now. So that gives us an opportunity of assessing the patient regularly and asking our pharmacists to send out a supply of drugs to the patient. So we've been keeping the mail service pretty busy in that respect. And you know, arranging local bloods, for example, so that even when another cycle comes along, we can check organ function and all the other important medical bits that we do before dispensing more drug, despite the fact that the patient isn't there in front of us.
Do you think there's been some negatives in this, though, that you are worried that might carry on, but you think we need to bring back to how we used to do it? Whether it's maybe you haven't done scans as frequently as you would have because you know, to try and keep people away from hospitals, even though hospitals probably relatively safe place to be right now, given all of the precautions that are happening. But are there things that you would want to restart doing? So I say personally, you've both said it's been nice to do the virtual visits, and it's been good for us, for a lot of people, but I have to say that I'm a bit worried about sometimes prescribing treatments to people that I've not seen for a while.
Yes, I think that the phone visits, let's say 1 out of 2 or 1 out of 3, but we have to see the patient. So I'm starting to see them in the office right now for the next 2 months, just to make sure, because most of them I haven't seen them for 2 months. So just to make sure that I keep seeing them and examine them, and just to make sure they're okay. I think that's and for the CT scans, they've been delayed for 1 month. For most of them, not more than that. So it's not that difficult. But for the ones that were, let's say, post-surgery or post-radiation therapy, the follow-ups, they've been delayed for at least 3 months. So this is my big worry for them, just to start back. We had some really difficult part with the radiology department to make sure that those CT scans are done and the patients are followed, because they've been treated and you have to follow them and they have to get those exams, and they were not as important, I would say, as the ones on treatment. So I think those patients are still important, and we have to make sure that those scans are done. So that's the most difficult part we've seen in our hospital.
Just bringing those scans back when there's a backlog isn't that easy, because those X-ray departments might also wanting to space out timing of scans, so there's not too many people in the department at once. So there's a lot of challenges. I guess as we try to get back to normal, or Nicole, maybe I'll stay with you, because you do a lot of the procedures, and you mentioned earlier that you weren't getting referrals. And I think one of our big worries is that there are a lot of people who have lung cancer but don't yet know it, and they haven't been sort of entered into the medical system yet to get a diagnosis. So how are you going to cope with this potential influx, and are you going to make any changes?
Well, unfortunately, there is not that many more places in on the external for the external visits, but we had to be human and see that some of them they've had symptoms since, let's say, 1 or 2 months, and they're really sick and they have some pain and or they're coughing, or so we had to admit more patients than usually to make sure that those tests were being done fast enough for the patients. So unfortunately, because of that, we're not able to manage all the patients on an external basis as we do usually.
Do you have any sense of how long it might take? Is your hospital full now because you're admitting people who are sicker than they would have been?
The hospital is not full now, so we're still okay. So I hope I hope that we're gonna be all right to get to get back to normal and not being full. But I know summer is coming, and summer means lack of nurses in the hospital. So I hope everything's going to be all right. But we had to see that for some patients it was not okay to wait for 1 month to get all those tests done.
And what about in London? What's it looking like getting back to normal? Are you projecting that you're going to have to do additional clinics, additional operating time needed to catch up? James, what's the back to normal plan? I think Michelle, James is muted. I can tell you while we're just waiting to unmute James, maybe I can do it. No, Michelle, can you unmute James? In Ottawa, certainly there's a lung cancer surgery has been able to keep going okay, just a little bit behind, but some of the other cancer operations like breast cancer and prostate cancer, there's been a lot of backlog that we're going to have to catch up with. And then benign surgeries are then in line behind that.
I'm unmuted now. Yes, apologies for that. Can you hear me?
We can.
Yes, I made the mistake of going on mute and then they wouldn't let me unmute. Yeah, so thanks for filling in. That was exactly the point I was going to make, Paul. So I guess, you know, for the non-medical on the call, it may need some underlining. You know, I work in a cancer center, freestanding, but it is part of a very large general medical hospital. And when COVID comes along, intensive care facilities and anaesthetists become extremely few and far between because they're all busy dealing with acutely unwell COVID patients, nothing to do with the cancer practice, hopefully. But that meant that one of the very first problems that we've had is ensuring that patients with the best form of lung cancer, if one can use that phrase, that is early stage curable disease, could get access to surgery. And in many parts of the UK, lung cancer surgery has really ground to a halt and is taking quite a long time to begin again because of the pressure on both anaesthetics and operating theatre critical care support. At our centre, we very quickly took over a local private hospital. It was quite a surprising development, but the NHS bought a job lot of private hospital space, and we've been using that as a clean operating facility from early on in the pandemic, and that's allowed us not to get too far behind. But I know there are some practices where catching up with surgery, analogous with the diagnostic delays, which Nicole was highlighting, is a very major issue and will continue to be, because not only have you got a surgical waiting list which is backing up, you've got newly diagnosed patients coming out of services like Nicole's, who are also being added to the queue for surgery. Of course, there are ways of mitigating that, and my radiotherapy colleagues have been busy as well, providing curative radiotherapy for some of these patients. So, you know, we're able to be creative to an extent in the lung cancer service.
Yeah, we've done that too. We've done some radiation for some patients while we're waiting for their surgery. I agree.
Right, and there's a lot of cases now where radiation is probably just as effective as surgery. So
yes, don't mention that too loudly in the presence of the surgeons, but that's exactly right.
What about research, Professor Spicer, and your trials program? How are you able to get that back up and running? And do you foresee big issues over the summer, or do you think you're through this now?
Well, you're opening up the Pandora's box of is there more COVID to come? And I suppose that's not a lung cancer specific question, and we might touch on that later. But in the meantime, the process of restarting clinical trials is on the one part administrative, and one can always deal with that with a bit of imagination and determination. But on the other part, it's infrastructural. Again, a bit like, you know, if you don't have an anaesthetist and a critical care unit, you can't do surgery. And if you don't have a research nurse or a trials unit, then you can't do trials. So one of the early contributions that my research team made to the COVID pandemic was redeployment. So a lot of experienced nurses who'd been working on our trials, because we were no longer recruiting patients to trials, were one of the first to volunteer to go and help out in the critical care unit, for example, and learn to be intensive care nurses very quickly. And that made a huge difference in coping with what was quite a big demand at its peak in London for intensive care support and space and nursing and clinical care for COVID patients. So that redeployment of staff, of course, at that stage, it's just as well we weren't recruiting patients to trials. But as our redeployed staff have returned to us, and they're pretty much all back now because things have really calmed down, we're now in a much better position to get going, and that's what we're at the moment. But when you're running a portfolio of trials across a big cancer center that numbers more than 250 different studies, that's a lot of complexity and a lot of paperwork that goes with it in this highly regulated field.
Sorry, there's a bit going on in the hospital behind me. So if you... We
can't hear them.
Oh, you can't. Okay. With the research, James, one of the worries that we've had is it costs money to run a clinical trials program, and that often doesn't come from core hospital funding, or at least for us it doesn't. And so when we're not able to give the opportunity for patients to enroll onto trials, the income for the trials unit dries up, and ultimately that income pays salaries for the clinical trials nurses, and etc. And so we're having to navigate that right now. Have you had problems with trials from a business consequence of this?
Money is always a problem, no matter where you are in life, isn't it? One has to consider the business aspects. I mean, a lot of our redeployed staff were paid for by the acute hospital while they were doing that, so that took care of that part of the process. Of course, our budget is going to be blown out of the water by all of this, but at least in the UK, the health service has made it very clear that budget deficits like that will be covered. Poor old taxpayer at the end of the day ends up having to wear that, but so far, at least at face value, we've been reassured that money won't be an issue. A lot of our grant funding and funders have been extremely understanding, which is especially impressive given that a lot of charities that support healthcare are themselves underwater when it comes to their usual fundraising because of the implosion in all of our economies. We're sharing around the pain at the moment, I suppose, and I'm quietly optimistic that those of us working in healthcare, wherever we are in the world, have built up enough credit points with the public at the moment that stories about aspects of healthcare which are grinding to a halt because of a shortage of funding in the future will attract some pretty prompt attention from government and other key funders.
Let's hope so. Yes, and there's
always the optimist.
There's a projection in Canada that up to 50% of charities might be in severe trouble.
Yes.
Well, let's be optimistic, because I'm an optimist at heart. I think we're going to get through this. In the next 12 months, Nicole, I'll come back to you first. Could you try and get out your crystal ball and project 12 months from now? Do you think that we'll be back to normal? Do you think we'll be back to a new version of normal, and we'll just look at this as a tough 6 months? Or do you think there'll be ongoing issues we'll still be facing?
I'm worried about the diagnostic tests that are going to be a bit delayed. I'm worried about that. From the medical point of view, I think we're going to be able to catch up to see the patients, but I think some part of phone visits will stay. From the research point of view, we're still off now in our center, so it's a big issue from the administrative part that we're not able to start again the recruitments. And I think the other thing is we'll have to make sure that for the patients, as I told before, that we still talk about what they wish for their health, and make sure also that they because some of my patients, they just stopped exercise because of the COVID. They were afraid to go outside and they were afraid to move. So I think that's something we have to keep. We know that exercise is really good for cancer patients in general. So I think that's something we have to make sure that is some started to walk and they were not walking before, but I think that's something we have to talk with them, make sure they exercise and they keep keep their shape to make sure that they are able to have a better quality of life.
Yeah, actually, interestingly, on exercise, my 92-year-old father, who's in Somerset in southwest England, has never been one for exercising, but during the lockdown, he started walking a mile or so a day. So maybe we can give that as a general advice to our cancer patients. James, the next year or so, if you could look ahead to 2021, do you think, are you feeling optimistic that, you know, I think when we've been
really
preparing
my optimism, I suppose, that this kind of timescale is a worry. So, I mean, I think there are a few things where we know we're riding for a fall, and that I'm thinking particularly here about diagnostic delays. My colleagues and I have just had a paper accepted in Lancet Oncology, which models the impact of cancer mortality, including lung cancer, from the diagnostic delays that have happened so far. You know, that doesn't even take into account any further delays, and assumes that all presentation and diagnosis will be without delay from here on. And we know that there's going to be an excess of cancer-related deaths, unfortunately, as just as a result of the delays we've been discussing. So it is so vitally important that we encourage and facilitate patients to come to appropriate healthcare when they're worried about symptoms that may represent a diagnosis of lung or other cancer. And that's got to be a very major priority in the immediate months. Much harder to predict is where we're going to be a long time from now, say summer of next year, and I think a lot of that depends on things outside of the control of people like you and me, Paul, and that is our, you know, our smart friends in ID. What we need is, I mean, you know, some progress with the vaccines, and obviously many billions of dollars are being spent globally in that initiative, and I think ultimately we're going to need at least one successful vaccine to really put this virus behind us, because even if we control it out of existence, like you know, for example, New Zealand seems to have done, one day we have to return to a global existence as a society, and sadly the lack of healthcare in less developed parts of the world will guarantee that there's always some areas of the globe where the human population is affected by this virus until we have proper ways of controlling it. So I think this is going to be here in the background, and we'll be dealing with periodic recrudescence and re-emergence of infection. And that's going to have an impact on how we manage other areas of healthcare inevitably.
But I think if patients, I think that what we have to do now is that people are really tired of social distancing. They're tired of wearing a mask. They're tired of everything. So we have to really make sure that they keep doing that, to make sure that we don't have that a big second wave of COVID. I think that's really important. I was in a clinic this morning, and some patients, they're just tired of all doing those stuff, and they say it's gone, there's no more COVID in the Eastern Townships. I don't mind, but we know that the second wave is coming. So I think we really have to keep telling them that it's important to protect themselves and protect the other patients also. So I'm optimistic. I think we'll have a vaccine next winter. I'm optimistic.
I think that's a message that we've been trying to get out as well through Lung Cancer Canada to people, is if you feel unwell and you have symptoms that are bothering you, don't stay home because you're worried about going out, because the bigger problem might be what's inside you now rather than potential threat of coronavirus. So if you do feel unwell, seek that medical attention, put a mask on, and hospitals are pretty clean and safe places right now. James, when we were emailing back and forth a little bit between the preparing for this, you mentioned a couple of things that you might see changing in the way we practice, and one of them I made a note of was this one-stop visits, where somebody may be coming for their next round of chemotherapy. They would see you, have a blood test, have the treatment all on the same day, as opposed to maybe spreading it out over a few days for logistical purposes. Do you see those kind of structural changes being something that you're doing a year from now, or is it going to be too complex?
Yeah, I really hope so. I mean, this is in effect a zero-sum game, and we've only got so many scanners and so many clinic appointments without investing in a bigger building or more machines or more radiologists to report the imaging. But in our particular facility, we have both an MRI and a CT scanner co-located with our outpatients. So theoretically, if our if our population was a bit smaller, we could offer everybody one-stop clinics all the time, and that's certainly the aspiration. But when we're working at full capacity with the large number of patients we serve, and lung cancer being sadly as common as it is, that's a lot of patients to care for. And so nice to offer and to have as an aspiration that a patient can come along, have their scan, make sure their tumor is responding before they have their next treatment all on the same day. But we just don't have the resources to offer that to everybody all the time. During the worst of the pandemic, when the number of patients we had on treatment was reduced because of prioritization and because of the fall in numbers presenting, we were able to offer that to a larger proportion. And hopefully, we've streamlined that process so we can offer it to more and more in the future. And certainly, if I was a patient and I was traveling the sort of distances that you were describing in your practice, Paul, it would be sort of galling to come for a CT scan on a Wednesday and then drive back another 3 hours for your clinic appointment on a Friday.
Right.
And I think we owe it to our patients, just from the point of view of respecting their time and energy levels, to try and do a little bit better in that respect.
We've got about 5 or 6 minutes before we're going to go to some questions, and so in that time, there's two things I wanted to cover. So firstly, James, this is back to you. So Nicole and I are involved with working with Lung Cancer Canada in advocating for access to new treatments when they come along, and trying to get our health technology assessment processes to approve new treatments. And there have been some changes in the way the provinces have allowed us to prescribe drugs during the pandemic, so people can have an infusion less frequently. Have you had any differences, any changes in the UK that have allowed you better or easier access to treatments for patients? Anything that maybe we can learn from you in Canada?
Yes, rather in the way that the trials regulator surprised me with the alacrity with which they announced they were going to be quite relaxed about deviating from trial protocols. The funding gatekeeper for the UK National Health Service was very quick to say that one or two of the expensive drugs that were actually quite difficult to access for patients would be immediately accessible, just because they either reduced the need for visits in the way that you implied, or because it made the patient pathway, including going through extra scans and biopsies, a bit more straightforward. And one of those applies to one of the expensive new targeted therapies called osimertinib, which some of the patients listening to this conversation may be on. But in the UK, that drug is can only be prescribed routinely after more established drugs in a similar class have failed. And that's despite some evidence that actually suggests that going on that drug from the beginning may be a better tolerated and at least as effective way forward than switching drugs and having to go through biopsies and things along the way. So immediate access to that drug in patients who have this type of lung cancer for which it's appropriate is something that came through. And I think it's going to be quite hard for us as a community in the UK to go back on that, because it's so evidently the way to go. We'll have to see. I mean, in part, the decision not to fund that straight up was driven by money rather than clinical imperative, and we have to recognise that such is life in healthcare. If we spend $1 on one thing, we can't spend it on something else, and we have to recognize that cost effectiveness is important as well. But I think there are some examples like that which really suggest that you know, where there's a will, there's a way, and we can make it happen.
Thank you. Well, I don't want to gloat, but actually in Canada we did have access to that drug as a first-line option already. So maybe it can go the other way around, and NICE can learn something from Canada. But I won't gloat on that. Or maybe I think
also for targeted therapy, what the province did that was good is to because we have to ask for those medications every 3 months and make sure that we have CT scans and evaluation, medical evaluation that the patient is stable, still responding. But the government decided, well, we're just gonna make sure that every patient is okay until the 15th of July, and don't bother about us, don't send us any papers. So that was something really useful for our point of view for the patients.
That's good. And I think the other big thing that we were allowed to do very quickly was and if there's people on the webinar who have been receiving immunotherapy,
yes, we've
been able to give that less frequently, so a bigger dose but less often, so people are still just as safe and the treatment is just as effective, but they don't have to come to the hospital as much.
The question is, what are we going to do in the next few months? Are we going to keep those schedules, or are we going to come back to that?
I think we'd like to advocate for that, wouldn't we? So maybe just before I pass this to Christina, who's going to facilitate some questions, I hope. Would you, if you were going to just give one message out to people with lung cancer or their families who may be listening, what would you want to say as we move into this sort of next phase of the pandemic? Maybe Nicole, I'll come to you first.
I would say two messages then. I would say keep social distancing, keep washing your hands, don't be shy to come to the hospital if you feel sick. That's the first message I would say. I'm gonna let the Dr. Spicer talk, and I'm gonna maybe add that the multidisciplinary cancer conference, the meeting for doctors, we just changed them by web, and we found it particularly efficient, more than in person. The doctors, they still want to take care of you, and they're still willing to make the best for the patients. I think that's my message. But keep protecting yourself.
Yeah, I think it is quite a nuanced message. On the one hand, as you say, Nicole, it's really important that patients come and see us, and we're here for you when you need us. On the other hand, you know, needless social exposure is something we mustn't be complacent about. And I think that's quite hard to hear, particularly as we come out of lockdown and the media is full of how, well, in the UK they were saying on the radio this morning, somebody said, it's your civic duty to go to the pub this weekend when they open, from the point of view of helping these businesses that have been closed for all the time. So I think that's quite the wrong thing to say, even at a societal level, and certainly to our patients. So we need to be saying, yes, it's perfectly safe to go out to the park, if you like, with a mask on, perhaps early in the day before the crowds get there and when the sun's out. But go and take some exercise. Don't sit cooped up indoors in the middle of the summer because you think the virus is hiding behind every hedgerow. It's not, and it's social interaction you have to be careful about. And coming to hospital, we're very aware of that, and we'll keep you safe. And certainly in our cancer centre, everybody is questioned about symptoms, has their temperature taken, and at the height of it, we're having PCR swabs every time they came to the hospital. And similarly with the staff to keep everybody safe. So it is quite nuanced, and I think that's important, because some patients, it's like some people are more conservative, and no matter what you say to them, are going to be extremely cautious and wash their hand at every opportunity and not see anybody. And for those patients, I think we need to give them quiet reassurance. And other patients who are a bit cavalier and let slip in my conversation in the clinic that they were having lunch with their grandchildren over the weekend and were planning a birthday party next weekend. That's not the way forward, particularly if you're a cancer patient on treatment.
Well, so maybe I'll just try and pin you down on this, James. And it's a little bit of an unfair question, but I'm hearing what you're both saying, that there's a kind of a common sense middle ground here of, you know, do go outside and take some exercise, wear a mask, wash your hands, social distance. If you're feeling unwell, come to the hospital or seek medical attention, and we're here to help you with that. But the common question I've been asked in the clinic probably in the last 2 weeks is, can I hug my grandchildren? I've not seen them for the last 3 months. So that's to you, James.
Yeah, well, I think that's a tough one. I think for elderly patients, whether you've got cancer or not, you've just got to be careful. And you know, there's lots of things said without very much evidence about children and the virus. Certainly, we know that children are at extremely low risk of being harmed by the virus, but we don't really know so much about what they're like as vectors. I think we have to be concerned that a lot of children, particularly as the schools open up, are going to be spreading the virus amongst themselves, and they won't care about that and won't notice that. But I think their grandparents might if they're not very careful. My children's grandparents have suddenly become extremely competent at social media, and I've always been a bit skeptical, but here we are having a very well organized, thanks to you, conversation on Zoom, and I think you know, video contact is a great answer in that sort of context where you can actually see your family without actually being put at risk by them. I hope that's not too wriggly an answer for you.
And I would say it's summer. Just make sure that you see your family outside. So you can have a nice dinner outside with your family, and you can see them. So.
Thank you both. It is a tough question, and it pulls on our heartstrings when you have to say to somebody, look, maybe you should not see your grandchildren yet. Christina, I think you're unmuted. Do you want to guide us through some of the questions that you've been receiving?
Yeah, thank you so much for all three of you for taking us through this discussion. I think the questions that we're seeing, there are quite a lot of them, but we can see that there are centered around some of the themes that you've already talked about that sort of fear, but then the balance of wanting to return to life and being anxious about going out yet and being safe. So why don't we start at the beginning? And one of the first questions that we got was that there's a number of questions, a number of people that have asked about, are lung cancer patients more at risk of death if they catch COVID-19 than a regular person? So perhaps I can direct that question over to Dr. Spicer. What have you seen in the UK?
Sure, Christina. Yeah, that is a great question. And I suppose the short answer is we don't really know. And as I was alluding to early on, I think in this respect, we're a bit more confident than we were at the beginning of the pandemic, when we were still learning. We had everything still to learn about this virus, shall I put it that way. Some of the early reports from China suggested that lung cancer was a risk factor for doing badly with this virus, in the same way that some of the other now rather notorious risk factors like obesity and diabetes, for example, seem to be. But that almost certainly, looking at the data sets that were early to be published, was based on very, very tiny numbers and really couldn't be confidently interpreted. And quite a lot of the more substantial data, which has now been released, as well as anecdotal experience of many of us, is that cancer is not per se the huge risk that we might have expected in this context. In fact, talking to some of my immunology scientist colleagues, there's even a suggestion that the immunosuppression that goes with perhaps having cancer, and certainly with some of the treatments for cancer, may be quite a good thing in this respect, because the strange thing about this virus is that for many people, even adults apparently with risk factors, it can be pretty benign, and then some people, even young people, are very badly affected. We don't really know why that is, but it seems to be mediated by an excessively florid response by the patient's immune system to the virus. Why that happens in some people and not others, we still have no idea about. But it's quite easy to guess and hypothesize that in lung cancer and cancer in general, and perhaps patients on on immunosuppressive treatment, that may not be entirely a bad thing in that respect, because if the virus comes along, that sort of over response that we see in otherwise healthy individuals sometimes may be less likely to happen.
And we were afraid that immunotherapy was maybe associated with a higher risk of inflammatory reaction, but we haven't seen that, so we're happy about that too.
Yeah, absolutely. So, I mean, even if I have a patient who swabs positive in the clinic and they're due immunotherapy in the next few days, I would usually just defer their treatment by a week, and once they've stopped being symptomatic, they come in and have their treatment, and we really don't think that's a risk at all.
Well, the problem is we had to wait until their PCR test is negative, and that was quite long for some of them. That was our main problem.
Right, but whether that's the right approach, I think, is again debatable, because prolonged shedding, which is really inconsequential to the patient themselves, is a recognized phenomenon. So why withhold the treatment if they're completely well?
So its message is really that there's so much that we don't know yet, and there's still so much that we are still looking at. But however, it is possible to have lung cancer and to live through a COVID-19 experience. And in fact, this featured patient story that we have on our website this week talks about a patient and who shares her story about living with lung cancer, stage 4 lung cancer, and having COVID-19. And I encourage you all to check it out.
Christina, I might say, I would maybe rephrase what you just said. It's not like it's possible to have lung cancer and live through COVID. It's overwhelmingly likely that if you get COVID and have lung cancer, you live through it. And there might be a delay in treatment for a little while, but the vast majority of people will do just fine.
One thing, yes, I think I would completely agree with that clarification, Paul. I think one issue though, and this, I've just prefaced this comment by saying what I hope is self-evident and follows up on what you've said. Most people with COVID, and as well as most lung cancer patients with COVID, will not become critically unwell. But one thing that the data emerging does seem to suggest, particularly big cohorts from this country, the UK, is that if you're unlucky enough to be really sick with COVID and have, for example, advanced lung cancer, your chances of doing well are very slim, and that's where things like this advanced directive that Nicole mentioned earlier on is important. Patients need to think about, those patients need to think carefully about how aggressive they would allow their doctors to be, because we know patients with lung cancer requiring ventilation in an intensive care unit because they have such bad COVID disease, the great majority of those patients will not survive, and therefore putting them through the indignity and discomfort of going to a critical care unit is not the right way forward. Anyway, we're focusing here on a very tiny population, subgroup of our population. That's something that we have to deal with in a hospital setting, but I think for the average patient, the take-home message is the one we've just been rehearsing, which is that COVID is out there, and most patients with lung cancer, if exposed to it, even if they get the infection, are not going to be lastingly affected by it. That's a really important message. I agree.
My patients, they like to hear that in the last few months, because they thought it was automatic that they would die from it.
So, so 2 or 3 panelists, we have a lot of questions, and we have 3 minutes left in this webinar. So I'm going to do the next set of questions rapid fire, and if I can ask that you keep your answers brief, then we're trying, because there's so many here, I'd like to try to get through as many as possible. So one of the questions is that people want to go back to church. They want to see their church mates, but they're afraid of these large gatherings. Any suggestions or any advice on that?
I can take that one. So it's very regional. It's going to be very dependent on where you live. It's also dependent on who you are. So I think churches that are planning a phased comeback in an area which has not had high numbers, and if you are not elderly with other comorbidities or other medical problems, it's probably going to be okay. If you are still in, say, parts of Montreal or Brampton or Mississauga or different places in Canada where there have been high numbers and it's a bigger church and you're older, then I would suggest you wait. A lot of churches have gone to offering virtual services that you may have been taking part in, and I would probably just stick with them for the time being.
So the next question I'm going to direct to Dr. Bouchard. Dr. Bouchard, how practical do you think it is for people to be wearing a mask at 30 degrees Celsius? How do we ask patients to manage that?
Well, I am a respirologist. I see COPD patients are really sick and they're able to wear their masks. So we wear them every day, since 8 o'clock in the morning until 6 at night. So I'm sure they can wear it for 30 minutes while they're in the hospital. But they have to remember that they have to deep slowly and not being afraid, because the oxygen will come through the mask. So they have really to calm and manage their anxiety regarding the mask, but there's no danger for any patients to wear a mask. So I really think they should wear one when they come to the hospital.
Okay, so I have 1 minute left. I'm going to take 2 more questions. I'm going to direct one of them to Dr. Spicer. And we have a number of questions here about winter flu and COVID-19. And they're concerned about having both.
Winter flu? Yeah, so when the season comes, it's really important that people get vaccinated against flu. That's for one. You know, if you avoid one virus, you don't want another one catching up with you. And at a societal level, we certainly don't need our hospitals filling up with flu over the next coming winter season. So if there's a vaccine, accepted is the short answer to that one.
And Dr. Wheatley-Price, I'm going to direct my last question to you. And patients are really asking, what if there's a second wave in Canada? What sort of protocols have hospitals been taking to prepare?
So I think we'll find that hospitals, not just in Canada, but I'm sure James would say this in London as well, and whether it's in Sherbrooke or Ottawa, we have all learned a terrific amount in the last 3 or 4 months in going through the first wave, be it telephone calls and teleconference calls, to adjusting the frequency of treatments, to access to some of these oral medications, getting more personal protective equipment so Dr. Bouchard can do the bronchoscopy safely. So I think we've learned so much in the last few months that when we do see further spikes in this coming and until a vaccine's available, I hope that we'll be really well prepared and we'll have learned all of these lessons. And so we will be able to avoid hospitals and healthcare systems becoming overwhelmed.
And the cancer center, there are the places for the treatments. They're all separated now. They're not the 6 patients that were before all together. So we've learned that also too.
Yeah, I mean, very practical things like how the waiting rooms are set up has been changed. So I think that we should be okay. But pride comes before a fall, and we have to look, south of the border from where we are now, and we're just seeing, the trouble that's happening in a number of the states in the US. And, it's easy from Canada to feel a bit smug about that. But, the reality is that, if we're not careful and we don't continue to be, very aware of social distancing and hand hygiene and all of the things that we get told again and again, those kind of things could happen to us. So we're better prepared, but we still have to, as a society, prevent as best we can further waves from really spiking us.
So we are at the end of our time now. I'd like to thank all 3 of our clinical experts for their time today. There were a lot more questions, but what Lung Cancer Canada will commit to is taking all these questions, answering them, and we'll post them on our website afterwards, so that anything that we did not get answered will get an answer from our clinical experts today. And I'm just going to pass it over to Dr. Wheatley-Price to say a couple of closing words.
Yeah, so thank you, Christina, for coordinating this from the office.